Welcome to the conference session titled Understanding High-Risk MDS to AML. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Dr. Dale Schaar. Dr. Schaar is a medical oncologist at the Rutgers Cancer Institute of New Jersey. He specializes in the care of patients with blood cell cancers with a focus on the myeloid disorders, including acute myeloid leukemia, myelodysplastic syndromes, and myeloproliferative neoplasms. Additionally, he is one of the blood and bone marrow transplant physicians at Rutgers, and therefore able to manage all levels of treatment that may be required for these complex blood disorders. In addition to his 25 years of basic scientific research experience, he has clinical research interest in developing new treatment strategies for MDS, and he directs clinical trials for patients with acute leukemia, including studies for patients who have not responded adequately to first-line therapies. With that said, welcome, Dr. Schaar.
Hi, good morning. It's very nice to be here today. I want to take this time to thank the Aplastic Anemia and MDS International Foundation for inviting me to speak. Just working through some of the technical things here. Today we're going to be talking about the more serious end of myelodysplasia. I know that the folks earlier on gave a talk about low risk or early MDS. Part of my talk will cover some of that, just the overview of myelodysplasia in general. It'll help us to understand how this disease can progress over time into various stages and eventually in some patients to acute myeloid leukemia. So as I mentioned, as the very nice introduction highlighted, I'm here at the Rutgers Cancer Institute of New Jersey, and my specialty is the myeloid disorders and stem cell transplant. So we know that normal blood cells are comprised of several different types. There's the erythrocytes, which are the cells that carry oxygen in the bloodstream. So we have enough energy to do what we need to do, and so that we can transfer oxygen in and out of the body. There's various other types of white blood cells that have varying functions. The myeloid compartment comprises of the granulocytes or the neutrophils, as well as the basophils, eosinophils, and also monocytes. These white blood cells fight infection sort of on demand. They're the real-time protectors from infection. On this, the lymphocytes represent the smarter or the adaptive immune system, and they comprise of B cells, T cells, and NK cells. And these are the cells that are responsible for our responses to things like vaccination, which is a very key topic these days, as well as remembering infections that we had before, invaders that we had before, so the immune system can briskly respond to repeated infections. How does this blood system arise? So to understand myelodysplastic syndromes as well as AML, you sort of have to have a background on normal blood cell formation. So we have blood cells are born in the factory, which is the bone marrow in your body. So the bone marrow is found mainly in your long bones and your sternum. Within this compartment are a whole multitude of different types of cells of various stages of differentiation. In this bone marrow compartment, there are hematopoietic stem cells, which are really a key component of the bone marrow. Studies that have identified these stem cells have enabled a whole myriad of therapeutic interventions into hematologic malignancies and form the basis of our ability to do bone marrow transplantation. So essentially, you could take a hematopoietic stem cell from an individual and transplant it into another individual and recapitulate the donor's immune system. So this hematopoietic stem cell has the ability to differentiate basically down two different pathways. On the left here is the myeloid compartment, and those are the cells that we're going to really be talking about today. I mentioned before the white blood cells, the platelets, which help you stop bleeding, red cells that carry oxygen, and the various immune mediators that protect us from foreign invaders. And on the right side is the lymphoid compartment, and these are the cells, the T cells and the B cells, that are responsible for our adaptive immune system, our ability to adapt to remembering vaccinations, and also importantly telling our immune system what's you and what's not you. Self versus non-self is a key component of the immune system. When this is the normal hematopoietic cell development, or hematopoiesis is what the process is known as scientifically. There's also a malignant component of this, where a lot of the diseases such as acute myeloid leukemia or myelodysplasia, unfortunately, there's a mangled or a mutated stem cell that is able to give rise to certain progenitors, but these progenitors have ultimately lost their ability to function normally, and also lost their ability to respond to normal growth signals. And when that happens, that's essentially the genesis of a cancer, a cell that doesn't function well and grows out of control. So the myelodysplastic syndromes, my talk today is going to be focusing sort of on this half of the diagram, but just as an introduction to my talk, on the left side of this diagram is the low risk myelodysplastic syndrome, and on the other side, on the right side, is the high risk, and then the transition to acute myeloid leukemia. So myelodysplastic syndromes, over the years have been studied intensely, and a lot of different prognostic algorithms have been developed based on an individual's initial characteristics or initial data when they're diagnosed with myelodysplastic syndrome. So basically, we look at the number and the depths of cytopenias, like if somebody has anemia or just an isolated anemia, or they have low platelets or thrombocytopenia. The number of these cytopenias and the depth, how low they are on diagnosis, is sort of predictive on how this process may progress. And also the blast percentage, I'll be talking about that a lot. A blast is an immature, sort of a stem cell type of blood cell in the bone marrow that has the ability to differentiate into different lineages in the normal setting. But in the malignant setting, the blast is sort of an arrested immature cell that is able to grow on its own and go out of control. So when we talk about blasts in MDS or AML, those are typically the bad cells. And the blast percentage is sort of predictive of how fast one may move along this diagram of myelodysplastic syndrome. Because MDS is really a spectrum of progressive bone marrow failure. And depending on your initial characteristics, we can sort of predict how long it may take an individual, or if an individual will progress from low risk to more high risk or even to AML. And then the middle characteristic is an area that I'll spend a fair amount of time on, and that's cytogenetic abnormalities and molecular abnormalities. More and more characteristics molecularly are being elucidated in these diseases, and there's a train going by. That only happens a lot, so we'll get used to that. These molecular abnormalities are being sort of added to this prognostic model as more and more of these abnormalities are noted and characterized by researchers. So AML is sort of the most extreme progression myelodysplastic syndrome. So an individual, depending on where they may be diagnosed with MDS, they may traverse in higher levels of bone marrow failure over months to years, depending on the initial characteristics. And then finally, the last progression is to acute myeloid leukemia, where this blast percentage now is over 20%, and it can go up to possibly 100%, and that's actually leukemia. And it's treated much differently than myelodysplastic syndromes. So AML, or acute myeloid leukemia, normal blood cells are sort of crowded out and replaced by this monomorphic or this monotonous population of these purple blast cells. So this is another way to look at hematopoiesis. I've been showing this slide. I don't know if you can see down here. This is from like 2002. So this has really been a well-traveled slide for me. But it really outlines the developmental biology behind the formation of blood cells, or hematopoiesis, and where things, as you can see from this diagram, there's an orderly progression of blood cell development. And there's many different steps in between here. We don't exactly know how many steps till this break point. But as you can see, there's many different instances where things can go awry. So initially we thought that MDS or even AML represented a cancer cell that went along certain lineages, and then they were just arrested in development at a certain stage, the last stage. And that's how people developed AML. That turns out to be only half the picture, because that does happen. These leukemia or myelodysplastic blast cells do develop to a certain spot on this diagram, and then they become sort of arrested or stopped there. But the initial pluripotent or the multipotent stem cell is also abnormal. So there's a leukemic and an MDS variant stem cell that unfortunately has the ability to recapitulate this process. So we have historically developed medicines that might get rid of a blast population, but we've only more recently been able to sort of target the leukemic stem cell and eradicate it. And the presence of the stem cell is the reason why AML has that waxing and waning type of disease progression, where we can get somebody into remission, and then several years later it can come back because this quiescent stem cell becomes reactivated. This side is also important because this is the adaptive immune system, the lymphoid cell compartment. And these T and B cells, as we'll talk about later, are integral to developing strategies that will eradicate this pluripotent leukemic or malignant stem cell and prevent these diseases from coming back in an individual. All right, so one of the big questions that we get as leukemia doctors or MDS doctors is, how did I get this? How did I develop myelodysplasia? So a lot of people will be picked up just by having an abnormal CBC or blood test with their primary care physician. And that usually starts the process of investigating why these blood counts are abnormal. But there are only a few known causes of myelodysplasia or AML. There's a handful of germline or from hereditary mutations that can be passed along in families that are responsible for cancer and hematopoietic cancers. And these mutations, DDX41, RUNX1, GATA2, they run in families, and they're usually autosomal. I think these are recessive. So they are responsible for people that have more of an inheritable component of their diseases. There's other familial or things that run in families. One of the worst is unfortunately the TP53 mutations, or the La-Fermani syndromes, and they're now a very dominant disorder where there's many instances of cancer that may arise in somebody's family as this train goes by. Outside of these familial mutations, there are other triggers that can cause myelodysplasia to arise, and one of those things is treatment for a prior cancer. So prior chemotherapy, prior radiation to treat either lymphoma or a solid tumor, or chemotherapy for breast cancer. These treatments at a low percentage, maybe 2 or 3% of the individuals with these diseases or these cancers, even though they're cured from their initial cancer, they'll develop a secondary leukemia or myelodysplasia as a result of being treated for their original cancer. And also people that have been treated for autoimmune disorders like Wegener's or rheumatoid arthritis, some people that might be on medicines like oral cyclophosphamide to sort of treat these autoimmune disorders, they are also susceptible, and that also can precipitate a secondary blood cell problem like myelodysplasia. I want to add in, if you guys have questions, please just write them down as they come up, because we'll have time at the end to hopefully get through everybody's questions. Myelodysplasia and AML, they can arise from prior blood cell disorders such as myeloproliferative disorders or even myelodysplasia. I'll talk a little bit more about that in detail. And there's very few implicated exposures to DNA damaging agents that people come across in their occupations or in their environment where they live. So people that may have worked in a tool shop and cleaned their tools with benzene or toluene, these are known carcinogenic agents, and they can give rise to leukemia and myelodysplasia. But overall, we don't really know how the vast majority of the cases or the individuals with myelodysplasia or AML arise. Research nowadays is really focusing in on more higher resolution molecular analysis of blood of people with blood cell cancers and people who have no evidence of abnormal blood counts. And these studies, a lot of them came out of patients with other solid tumors where their circulating blood cells were sequenced, and they were found to have mutations that we commonly see in myelodysplasia or leukemia, but the individuals had no evidence of these disorders. They may have been treated for lung cancer or something like that. And these mutations in people that don't have abnormal blood counts that are, as far as we know, normal, were called ARCH, or age-related clonal hematopoiesis. These are just normal blood cells that a certain percentage of them carry a mutation or an abnormality in some gene that's not part of the normal repertoire of our gene expression. And it's thought that ARCH is a part of the normal aging process, and most of these cases, do not lead to blood cancers. But once you have one mutation, you're sort of on a road where if you get more mutations, that's sort of the hypothesis on how cancer arises. It's sort of a multi-hit process where one mistake is present. It doesn't cause that much of a phenotypic or a change in a cell's growth patterns, but it gets another one and then another one, and then all of a sudden the cell now is losing its growth control and becomes more malignant. So it's a risk factor for developing blood cancer. But there's also increased risk for other diseases, such as cardiovascular disease. So some of these genes that are abnormal in blood cancers are also seen in people with early heart disease. And the thought is that the blood cells are causing a nidus for abnormal inflammation in coronary arteries and maybe forming plaques and leading to early heart disease. When these ARCH mutations become more frequent, or when they're present in leukemia-associated genes, and their presence in their variant allele frequency, meaning the percentage of the mutated gene is at least 2%, then they're called CHIP, or clonal hematopoiesis of indeterminate potential. Now, CHIP is something that now gets our attention here as hematopoietic, or in heme malignancies, because these now are mutations in known leukemia-associated genes. They can be present in 1/10, 20% of the people by age 70, and in highly sensitive methods can pick them up in just about everybody when they're 50. And there's an absolute risk of between a 0.5% or 1% per year that these people go on to something like myelodysplasia or AML. So how does this look sort of as a picture? So diagrammatically, you have these cells that may have a CHIP mutation, or in general, a mutation in a gene that's involved in leukemia, and they somehow get a growth advantage over normal hematopoietic stem cells, and they become more frequent in the bone marrow, as you can see here, until their frequency, which increases because of their growth advantage, eventually develops into myelodysplasia and then eventually into AML. So this is sort of the cell process of how myelodysplasia and how eventually acute myeloid leukemia arises. And our focus today is on this area here, where people that already have MDS and now they're moving into perhaps AML. These are the group of individuals, if you're in this stage, this is where intervention or some treatment is required for the myelodysplastic syndrome. And here's another cartoon showing how we have normal hematopoiesis, a normal blood cell formation. You get a mutation, and now it becomes clonal. Clonal just means like they all look the same, and they all look the same because they have the same mutation, and they gain a growth advantage and then become more frequent. And as they become more frequent, then you start to develop MDS and then AML. Or you can develop AML straight away, and that's called de novo AML. If you develop AML as a result through an antecedent or an earlier hematopoietic problem like MDS, this is called a secondary AML. Again, sort of the same thing. Stem cells have all different progenitors, which have varying amounts of pluripotency, or the varying amount of ability to repopulate bone marrow. So the absolute stem cell, the one that we need for bone marrow transplant, is able to give rise to all these things. Whereas one of these multipotent progenitors may only be able to give rise to granulocytes. So this is an orderly stepwise process. And when you get mutations along the way, it affects different things, including the microenvironment and how gene expression occurs. And then these resultant cells become actually mangled, and they're as a result malignant. So our talk today is really a reiteration of this Venn diagram, where we know now, based on clinical observations and molecular mutations, that these sets of diseases are really highly related. So we know that myelodysplasia, when it becomes advanced, it can transform into AML. The same can be said with this other group of diseases, the myeloproliferative neoplasms. They can also, at certain percentages, evolve into AML. We know that there are mutations that are specific to AML or MDS or MPN, but there's also mutations that can be seen in all three of them. Sort of molecular verification that these are sort of related processes. And a lot of times you'll be treated for an AML that evolved from MDS, and you'll just get sort of knocked back into MDS by controlling the blast population. And that's going to be one of the therapeutic strategies that we'll talk about later when people present with either advanced myelodysplasia or on the verge of developing AML from their myelodysplastic syndrome. Okay. Get this to work. All right, so I'm not going to go too much through this process, but there are a lot of different molecular mutations, and it's sort of a colorful slide. But there's different genes here that have varying prognostic implications, or meaning if they're damaged in an individual, they may have, a more favorable, may denote a more favorable myelodysplastic syndrome, or one that might be more serious. And as science goes forward, we're able to sort of pick out all different categories of these mutations, and they're in different molecular, they have all different molecular functions, either from proliferation or for controlling gene expression to other things. So when we talked about that one slide that I had about myelodysplasia and how it's low risk on the left side and high risk on the right side, we sort of denote where somebody is on that spectrum by using currently now the International Prognostic Scoring System and the revised edition. And so this IPSSR score assigns people into 5 different groups. And by looking at many patients, many thousands of patients, based on 5 disease factors, we talked about some of them, essentially the blast percentage, molecular abnormalities, the number and the depth of the cytopenias. We can categorize people as having either very low risk MDS or low risk MDS, where care is mainly supportive or with growth factors, or it can progress, you can present or progress to intermediate or to high or very high risk disease. And very high risk disease, now we're talking about people that, in this category, they need to have some intervention with their disease, probably within a year before they start to get into some issues with myelodysplasia. So these are just the numbers that we look for, the molecular abnormalities or the chromosomal abnormalities, the blast percentage, and how low your hemoglobin or your platelets are, or how many infection fighting cells you actually have. This is how we get numbers. Each one is is assigned a score. So if you have good cytogenetic abnormalities, you get a 1. If your hemoglobin is less than 8, you get 1.5. As you can sort of figure this out, you add these things up as you go down, and you get a final IPSSR number. And if your number is low, like 1.5 or less, you're in the very low category, and these a very low risk category. And these patients may stay in that left-hand side of the myelodysplasia spectrum, if you will, and they may only have an issue with one cytopenia, maybe refractory anemia, and their issues may not be so much a progression to leukemia, but more or less a problem of keeping their red cells up so they can have a good quality of life. And then their problems may be more along the lines of, not responding to growth factors and having issues with things like iron overload from getting a lot of blood cell transfusions. Intermediate, now we're talking about, so here, a lot of these patients may never develop AML, and they may be, 10 years or more away from having any problems from their myelodysplastic syndrome. As you go down, that number 10 goes down a little bit lower to the very high end. Then we mentioned that people within a year, they'll have to come to some kind of treatment or else get into serious trouble from their disease. We have other categories that we're starting to find out more about. There are certain mutations now, like citrate dehydrogenase 1 or 2, IDH1 or IDH2 mutations. When these are present, it's important to know about them because there's new medicines now that have been developed that target these mutations and sort of can pull people out of AML, start to control AML, or actually improve their cytopenias from myelodysplastic syndromes. So these oral medicines now are a very solid addition to our repertoire to treating myelodysplastic syndromes, but their frequency is not very high. It's on the order of 5% or less. And then there's another syndrome where there's just a deletion in chromosome number 5, the long arm of it, and it's called the chromosome 5q or 5q syndrome. These patients are thought are clinically more favorable because they can respond to medicines, specifically lenalidomide or Revlimid. Up to 70% of those patients will have improvement with their cytopenias or low blood counts with the addition of the medicine Revlimid. So we have this whole overview of myelodysplastic syndromes, and we go from an unexplained low blood count to like finding mutations and then working out the clonal aspects of things and then sort of diagnosing myelodysplastic syndrome. This is sort of where this talk begins therapeutically, because once you have a myelodysplastic patient and they're in a situation where they can be treated with anything that's available, they're sort of they're broken into different categories, whether somebody's eligible for a stem cell transplant or not eligible for a stem cell transplant. And we'll talk a little bit about that eligibility, but that is really the driving factor here, because we're developing a lot of new drugs that are giving us a lot more confidence in treating people with myelodysplastic syndromes. But historically, an allogeneic transplant is the only known method right now that we know of that eradicates this disease. So we have to know from the beginning if this is something that we're going to be able to do, and then we sort of dedicate our treatment towards this goal of getting people to an allo transplant. And then we talked about low risk, high risk. The low risk is more growth factors. We talked about Revlimid and other things, transfusions. And then we have the higher risk, which is mainly the focus of this talk, and that requires now treatment with chemotherapy or a bone marrow transplant. We pretty much went through all of these things. Allotransplant is really the main therapeutic intervention that's able to alter the disease course. So now going back to this, we are clearly now from this half of this diagram now, from high risk to AML. So high risk is usually denoted by an increasing blast percentage, okay? So as this blast percentage, people may be diagnosed with a myelodysplastic syndrome with 8% blast or 7% blast. That's still like intermediate or high intermediate disease. That's a disease that we would go on and we would treat, because we would need to lower this blast percentage for as long as we could to sort of circumvent or at least delay any progression to acute myeloid leukemia. These other things are more predictive, but this is more of an actionable thing, and that's really a sign of an increasing blast percentage is really the hallmark of high-risk AML, this border here. So over here you have, the pathologist will tell you that, oh, there's 15 to 18% blast. And over here, AML is characterized by 20% blast. But the reality is this is all the same disease. So if your blast percentage is up there, clinically it's really AML or acute myeloid leukemia, and sort of needs to be treated as such. So when we talk about high risk and MDS, we're talking about the IPSS-R score of intermediate 2 or high or very high. Those are the categories that sort of trigger more aggressive treatment and more, and making the decision of whether or not an individual is an allogeneic transplant candidate or if we have to go through other things to control their disease. And we'll talk about these things a little bit more in depth. So the first thing, if somebody is diagnosed with a myelodysplastic syndrome and the blast percentage puts them in intermediate 2 or high risk disease, meaning that their blast percentage is over 10 or 10%, 8%, up to 20%. This is high risk disease now, and now that requires treatment with now chemotherapy. And the hypomethylating agents, which the shorthand for that is HMAs, are a class of drugs that were the first chemotherapeutic agents that have had that have altered to have improved survival in patients with myelodysplastic syndromes. So they are a huge development for us. So these hypomethylating agents, the ones that are clinically used are azacitidine, and the other one is called decitabine. It's not on this slide, but they're very similar agents, and they do the same thing. They hypomethylate the DNA, means they decrease the methylation of the DNA. Methylated DNA is essentially shut off DNA. So in myelodysplastic syndrome, there's not normal blood cell formation because there's mistakes, mutations that sort of prevent normal gene expression occur, that prevent normal splicing of genetic messages, mRNAs, and these type of lesions that prevent these cells from growing up normally. And the hallmark of shutting down gene expression is methylating the myeloid specific or the white blood cell specific genes. And then these agents sort of reverse that hypermethylation by creating more of a normal methylation where the needed genes for white blood cells are now re-expressed, and you can reestablish some blood cell formation. So the first class of drugs that significantly improved median overall survival, better 2-year survival rates, there's less toxicity. These are outpatient drugs. They can be given in the clinic. I have patients that have been on them for years. The caveat to that is, for some reason, we're trying to figure out is a lot of the patients will have a good response for maybe 1 or 2 years, and abruptly lose a response, have to move on to other therapies. What the reason for that biologically is still unknown to us, but it's an area of a very intense molecular and clinical investigation. And this survival benefit is pretty much seen in all prognostic groups. And it's really unclear if there's a real difference between azacitidine and decitabine. But azacitidine is the only one that really has been shown in clinical trials to by statistically significantly improve overall survival. So we talked about decitabine. It's very similar. There's other agents that are second generation hypomethylating agents. The guanidicitabine is more stable, so it's thought to hang around a little bit longer in the body, so it will reverse some of these methylation changes longer and lead to hopefully a better clinical response. There are now, very importantly, oral formulations of these drugs, Onureg and these other ones. There's a combination with decitabine and cytarabine, which is an inhibitor of the breakdown of this drug, so that there's higher levels of decitabine in the body for a longer period of time. And then the oral form of azacitidine is called Onureg. So these drugs are very important because people that are diagnosed with myelodysplasia are most frequently a little bit older. The median age for AML or MDS is probably when an individual is in their mid-60s. Although we've seen patients in their 30s with these these abnormalities. But by and large, they're more frequently seen in the elderly population. And when I say elderly, I just mean over age 60, and not just the nomenclature used by some of us hematologists. There's a lot of new drugs in development that can be added into this scheme. So you have hypomethylators. Now we talked a little bit before about the IDH1 and IDH2 inhibitors. These were developed for people with AML that didn't respond to the first-line therapy. And the overall response is 30 to 40%, and these are oral drugs, which makes quality of life much better. And they're frequently used as a bridge to a stem cell transplant, because the whole scheme here is to decrease the blast percentage and as a bridge to getting somebody to an allogeneic transplant. And there's studies ongoing adding these agents together with hypomethylating agents. Those studies are more in the phase 2 or intermediate clinical trials. I suspect there'll be more definitive data within the next 6 months to a year. I alluded to before the instance where we have somebody that responds to Vidaza or decitabine, the hypomethylators, and then they abruptly lose their response. These individuals are characterized as having a HMA failure or hypomethylator failure. And this, for reasons that we're working out, as I mentioned before, it happens typically 1 to 2 years after having a good response. They abruptly lose it, and then at that point, they sort of have to go on to other treatment. But second-line treatment for myelodysplasia is certainly a work in progress, and there's a lot of new drugs that we're evaluating. But at this point in time, if an individual has moved into the more higher risk range, then we have to really ascertain whether or not, an allogeneic transplant is appropriate. And I should say right off the top that myelodysplasia, it is a stem cell disease. It does have varying courses in individuals, meaning how long people might have before they get into a lot of problems from the myelodysplastic syndromes. But from the beginning, individuals should be seen at a center that does allogeneic stem cell transplant, just to get themselves on the radar, because going to transplant is not something that we can just do in a week. It takes a workup for the patient, and that's required to find a proper donor for these individuals. So an allogeneic transplant, an allo transplant, allo means other. So that means you get a transplant from somebody else. You get blood cells from somebody else to recapitulate the donor's immune system. And the whole thought behind that is the donor's immune system now will recognize the myelodysplastic cells as being foreign and eradicate them. So, and this happens on a 24/7 constant basis. So there's no treatment just when the drug is available. A stem cell transplant is like a living therapy that's there 24/7, hopefully eradicating the disease. So individuals, if you're diagnosed with myelodysplastic syndrome, I would recommend that you go to a center, at least initially, that has more of a specialization in myelodysplasia and has the capability to do stem cell transplantation. That way, your treatment course can sort of be mapped out with that in mind. Care for myelodysplastic syndrome certainly can happen locally with the hypomethylators, but you need to be sort of tethered to, I think, a more of a tertiary or higher level center that has transplant capabilities. Said that. So once you get into a situation where you're not responding to the best drugs that we have and you're high risk, and we're moving towards transplant, so the main thing now is sort of a transplant evaluation. Now, clinically, what we need to do is, if you're moving now, progressing with your myelodysplastic syndrome, by and large, that means an increasing blast percentage, sort of creeping a little bit closer to that AML border. We would have to do some chemotherapy that'll do cytoreduction, meaning reduce the blast percentage. Because if we can go from a blast percentage that's 18 down to the one that's less than 5 or even less than 2%, that's very, very favorable. And that's a situation that you would like to be in going into an allogeneic transplant. You don't want to go into an allogeneic transplant with 18, 15% blast. If that can be avoided, outcomes are better the lower the blast percentage is. So we do some things before a transplant to try to lower that blast percentage. There are some individuals that, because of their underlying medical problems, as I mentioned, these diseases happen much more frequently when they're older, when you're new. Individuals may be in their 7th or 8th decades, and they may have accumulated medical problems such as emphysema or heart disease or heart failure. These patients, the toxicity from transplant would be prohibitive, and certainly they wouldn't be candidates for this procedure. And then they would go on to other types of treatment like clinical trials or other combinations, medical combinations, to try to control their disease and to sort of stave off that fulminant progression to acute myeloid leukemia, with the caveat of providing always best supportive care for everybody so that people can maintain their quality of life. So one of the key drugs, in this sort of MDS to AML sort of transition or a segment of myelodysplastic syndromes, is this drug called venetoclax. And venetoclax is essentially a pill that was first shown to be effective in chronic lymphocytic leukemia, or CLL. Particularly, it was effective in patients that had mutated CLL with mutations in TP53 and resistant to most other chemotherapies. It's been shown to be advantageous when it's added to hypomethylators and quote-unquote elderly AML. It just means people that are over 60, and I also am a little bit offended by this elderly as I approach 60, but this is just a clinical delineation. But this population is very difficult to treat. When you get acute myeloid leukemia, when you're older than 60, or if you get acute myeloid leukemia that arose from a prior blood cell disorder like a myelodysplastic syndrome, it's a difficult leukemia to treat, and not one that's really thought to be curable by chemotherapy alone. Those people would need transplant if that was possible. But this venetoclax has been combined with AML therapies, and it's really increased the complete AML. And it's been a huge advantage for us, a huge success, because now we can treat people with venetoclax and hypomethylator, or add venetoclax to a hypomethylator that might not be working as well anymore. And using this combination now, we can lower an individual's blast percentage and maybe bridge them to transplant. When you're at the MDS AML border, that just means your blast percentage is probably around the 20% number. And these patients, if you're a candidate, meaning that you're well physically, you may be need treatment with induction chemotherapy that's designed for patients with AML. And 3+7 just means that there's one drug called idarubicin or dautorubicin that'll be given for 3 days, another drug called cytarabine that'll be given for 7 days. So that's how we sort of shortened it down to 3+7. That's standard of care induction chemotherapy in AML. And that, when we say induction, we're just trying to induce a complete remission, or trying to induce a state where the blast percentage now is low or even undetectable. There's other drugs that have been added to this backbone that has been successful. Things like Mylotarg, which targets certain markers on leukemia blasts. But there's been at least 8 new drugs that have been approved recently for this indication. And now we're just in the process of sort of mixing and matching and trying to find the most advantageous combinations of these drugs to either control or eradicate these diseases or get people to transplant. So when you get to this border with AML and MDS, some people are candidates, they're well, and they're candidates for the intensive treatments such as 3+7 and CPX 351 or Vyxeos, or less intensive treatments, which can work to the same end, which is decreasing blast percentage. Vyxeos is an important drug which uses the backbone of 3+7 cytarabine and daunorubicin, but it's formulated such that the drug is at an optimized ratio of 5:1 in liposomes, which are just sort of lipid-containing little microscopic drug delivery vehicles, and they go right. They're preferentially picked up by leukemia cells, and they hang in there longer time, so they act longer on these leukemia cells, killing them off longer. And older patients with either therapy-related AML or secondary AML, they would be candidates for Vyxeos therapy. And there's a special population of people that have a good response to Vyxeos and then go on to transplant. They're the people that end up doing the best on this drug. It hasn't yet been shown to be that much better than just standard 3+7 in all comers right now. So we have about 9 minutes. Hematopoietic stem cell transplant is the way that we can cure myelodysplastic syndromes and high-risk AML. And we're talking about patients that have achieved an IPSS-R score of at least 4.5 to 6, or very high, greater than 6 points. Now, these people need to be initially just fast-tracked right to transplant. People say, oh, when should I get a transplant? If you present like this, the best thing would be to head right to transplant. But if you present with an IPSS score of like 1 or 2, you can be watched for months to years without needing any escalation of your treatment. So the real key in timing of transplant is to sort of optimize the time before and the time after transplant. So you don't want to, because hematopoietic stem cell transplant has its own potential complications. You can even die during transplant. We want to minimize these risks in people that are doing well and don't need much intervention in the myelodysplastic syndrome. So that's why I'll recommend that people be watched closely for months to years before moving to an allo transplant. And the ticket to really move is when the IPSS-R score sort of gets into this range, or there's a change in category from intermittent 1 to 2. Or if you have developed high-risk molecular characteristics, then we would go right to transplant. So who is the individual that would go on to transplant? And anybody that has myelodysplastic syndrome represents a potential candidate to be a transplant, because we had said all along that myelodysplastic syndrome is only really eradicated by getting an immune system from somebody else. So we know what the disease indication is, but who goes on to a transplant is sort of, we sort of compile all this data, some of which is disease specific, meaning, adverse cytogenetics or adverse molecular abnormalities. Some of it is a person's past medical history, like if they have issues with cardiac or pulmonary lung function, or liver problems. These things may exclude individuals for transplant. And I don't mean exclude them, meaning that, oh, we're not going to give you a transplant because we're not going to give you a transplant because we think you'll live longer if you don't have a transplant. And that's the main criteria for selecting candidates. And things that you can't change by and large, and that's your age, also your gender, but also, your performance status, how much you can do. So how much you can do on your own, how debilitated you may be because of these things, is very informative on how somebody will do in a transplant. So somebody that's, is kind of like working through things and they're deconditioned and they spend more time in bed than not, that's not an individual that we would predict would have an easy road with a stem cell transplant. This can change as, disease treatment is optimized, but certain things like age cannot change. and the variability or the characteristics of the disease doesn't usually change either. And it also requires kind of a village. That's the way I think about, the care of and the initiation of the stem cell transplant. You need a lot of different individuals with different specialties, and you need to have certain things to happen clinically for the treatment of myelodysplastic syndrome. So you need a disease response. Mainly, you need to decrease the number of those bone marrow blasts, and that will optimize an individual's chance to have a very positive result with the stem cell transplant. You need to have the availability of a suitable bone marrow donor. You need to be able to support yourself psychosocially and financially during transplant. Mainly because the medications that are required after transplant, they could run, $15,000 a month. So you need to have insurance support to pay for those meds. You have to have the ability to follow up at the transplant center. And I put down here physically and mentally. That means you have to be here when we ask you to be here for blood draws, and because we're constantly monitoring drug levels and disease states. But you also have to be available mentally to be able to make the on-the-fly adjustments that are required in somebody that undergoes a stem cell transplant. So you need to, essentially, have the ability to be highly compliant as a patient. And then we talked about the underlying medical problems, how much you can do, what's your performance status, and how old you are. The age used to be a cutoff when I first started. I don't want to say how many years ago, but I wouldn't be a candidate for transplant when I started because we didn't do full transplants in people that were over 55 years of age. Now we've moved that age bar up probably 2 decades into the 70s. People in their 70s, if they have a good performance status and they have manageable or controlled medical problems. So age is going up. We're able to do transplant in many more people, but it requires sort of the right individual, the right care for all these things to come together to, have the best chance to have a good outcome with transplant. There's many different avenues of investigation for people with myelodysplastic syndromes and AML. They're sort of hand in hand. The lower risk myelodysplastic syndromes, I'm sure you heard earlier about luspatercept as for people that don't respond to erythropoietin stimulating agents, growth factors such as white cell, Neupogen, Neulasta. There's diseases that are specific treatment for these very tough molecular abnormalities as well. There's drugs that are specific to target the p53 mutated patients, and they're a very difficult set of diseases. And these mutations in p53, which is really, I had this cartoon in here because it is considered the guardian of the genome. So p53 is a protein that sort of monitors your DNA status, and if it's broken or mangled, it signals that cell that has the damaged DNA to die. So if you lose this DNA sensor, cells that have damaged DNA aren't signaled to die, and they go on to be more mangled and become more, they go on to becoming a very resistant cancer. So we have medicines that are specific for that. I won't go into that too much detail because we're running out of time. There's a new medicine called magrolimab, or targets CD47, which is a marker on cells, and it's really a checkpoint inhibitor, meaning that it's sort of if it's on the cell, it tells the cell not to eat me or not to phagocytize me. So cancer cells, of course, overexpress this because they don't want to be eaten; they want to go on and grow. The medicines that sort of target CD47, they mask it and they get rid of the signal so that these cancer cells now can be gobbled up by the normal immune system. And it also works in people that have p53 mutations. So this is a drug that's being studied in AML and also high-risk MDS. A new therapy, I know I have a minute left, but the new therapeutic applications are called BITE or bispecific antibodies, where there's a protein antibody or protein that links an immune cell with a tumor cell and causes a recognition here from the endogenous immune system to get rid of this cancer cell. So these bridging or DART antibodies or BITE antibodies are very much progressing through clinical trials, and they're very useful molecules. They're more advanced in diseases like lymphomas and CLL, but they're also being developed for AML and MDS. And we talked a little bit about the checkpoint inhibitors, meaning that you want to sort of rev up or unleash the immune system by sort of inhibiting signals. It's kind of a double negative, but cells that are turned off, you want to prevent them from being turned off so that they can be activated and in turn identify the tumor. And all these drugs are being paired with hypomethylators, and this is probably the next generation, the next step in drug development for myelodysplastic syndromes. So I think that's all I wanted to go through today, and I'd be happy to entertain some questions. I appreciate everybody's attention this late morning, early afternoon.
Thank you, Dr. Schaar. We do have several questions. This patient is asking, my most recent bone marrow biopsy showed a mutation DDX41. My father had MDS, but no bone marrow biopsy because of his advanced age. I'm currently undergoing genetic counseling to determine if I inherited this. Will they be able to tell if my sons carry this mutation too?
Yes, they will, and that would be the recommendation. So then it's very important and essential that they identify that marker in you, and your children should be tested for them. If you go on to a potential allogeneic transplant, if your brothers and sisters are evaluated as being donors, they need to be tested for that as well, because we probably wouldn't use them as donors if they had that. And if your children have the mutation as well, they would just probably need a little added surveillance in their medical care going forward. It's not a guarantee that there's going to be a problem, but it does put everybody at higher risk.
Thank you. This is from another patient. What are the clinical implications of bone lesions identified on an MRI? Personally, I have had low-risk MDS since 2012 and have become transfusion dependent.
2012. I mean, that's consistent with being low risk when you were diagnosed. I do see a lot of patients that are sort of sent to me because they have abnormal MRI findings. Either their bone marrow looks a little bit too geared up. I think an assessment may be done, like repeating a bone marrow biopsy, to see if your disease has advanced. But if there's discrete abnormalities, unfortunately, people can get more than one disorder. So those lesions may need to be, investigated clinically as well, separately from a regular bone marrow biopsy.
Thank you. Here's another question. When will you use decitabine as opposed to Vidasa for MDS?
Well, that's kind of like a gray area. It's sort of, I think, clinically, there's probably not a lot of difference. Initially, there was, people were all treated with Vidasa because that was the medicine that had the clinically significant result of increasing overall survival in patients with myelodysplasia. But decitabine has been employed in combination with venetoclax in patients that have had advancing blast counts and more proliferative or growing fast disease. So some people will do that, and also because of the clinical schedule, that's only a 5-day infusion versus 7. But I think, again, now the pendulum has swung back to, I think more patients are being treated with azacitidine, because I think there's a little bit less in terms of side effects, particularly GI.
Thank you. Here's another medication-related question. Do you need a good performance status to receive azacitidine and venetoclax? Can this be given outpatient?
See, that's the great thing about that combination. It was really shown to be effective in people that were a little bit older and they have a little bit less of a performance status. There's a whole spectrum of performance status from like not being able to mow the lawn to being in bed all day. So it depends on, what's somebody's actual performance status, but the combination usually can be given in most patients if they're medically stable. Otherwise, we do sort of, we can give people a more conservative treatment to begin with to see how they react and then escalate as needed or, pull back as needed in terms of the days of decitabine infusion or how many days you stay on venetoclax in one 28-day cycle.
Thank you. This patient is an IPSSR low-risk MDS with ring sideroblasts, still transfusion dependent despite a maximum dose of luspatercept. Would you start hypomethylating agents?
Yeah, I think that's kind of the progression. If you go through you go through the Procrit or the Aranesp, and then you go to luspatercept, and if you're on the highest dose, people that get to the highest dose of luspatercept, I think there are 3 dose escalations. So if you're at the highest dose escalation for 8 to 12 weeks, and you're not getting where you need to be, then we would consider treatment with hypomethylators. The supportive therapies like luspatercept are mainly there because we don't want, if we can improve transfusion requirements. So we may not be able to totally alleviate one's transfusion requirements, although that's the goal we strive for. But if somebody's transfusions from weekly to monthly, that would be a positive effect of luspatercept. But for refractory anemia, the next step might be either IDH1 or IDH2 inhibitor if that's present, the mutation is present, or hypomethylator.
This is a question related to transplant patients. Do you have any opinion on release after a bone marrow transplant? Some centers are releasing patients after a few days to stay in close proximity, while others are requiring patients staying for several weeks.
Well, again, it kind of depends on where you are. Here we are in Rutgers, we're surrounded by many, many transplant centers within an hour or 2 hours. Other places in the country, people may have to travel 6 or 8 hours to get to the transplant center. So that logistics, may require people to stay around. I can only talk for our center. For an allogeneic transplant, we tend not to do those transplants with outpatient. Whereas autologous transplants, meaning transplant using an individual's own cells, those transplants we can at least start as outpatients. We usually have patients that they require somewhere around a 3-week admission to the hospital because we like to see people's counts sort of engraft before we set them home. And then a typical follow-up would be, 2 visits a week in our outpatient clinic until things sort of stabilize out.
Thank you. And our final question, how do you manage a patient on Prograf after transplant and despite the lowest possible dose is still having significant cytopenias?
So Prograf, that's one of the things we always check when people come in to outpatient clinic. There are certain therapeutic levels that we want people to stay in for Prograf. Sometimes cytopenias may not necessarily be due to Prograf, and they may be due to the graft itself, and more time may be required for that pluripotent stem cell to sort of take over the bone marrow. In the beginning after transplant, there can be waves of stem cells that sort of take over that have more limited stem cellness or pluripotency, and they sort of fade out with time. And then you just have to sort of hang in until a pluripotent stem cell takes over the bone marrow at the same time watching to see if everything else is minimized, meaning any other drag on the bone marrow, and always watching for the primary disease to come back. These are some of the things that we look at when people come in the outpatient clinic. Really a very big subject. I can't really do it extreme justice right now, but that's sort of the gist of how I would deal with it.
Thank you, Dr. Schaar, and that concludes our question and answer period today. And thank you again for sharing your time and expertise with us today.
Oh, thank you very much. Thank you for having me again. Have a great rest of the weekend.
If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If you were not able to have your question answered today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Be sure to visit the exhibit hall. The next educational session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family, as we have for the past 38 years. This concludes a session.